Yep, many thanks, Cha, for this introduction. So this webinar uh, includes a set of slides that I've presented to a smaller group, I think around about a week ago, on the same topic. So this is an extended slide set here. I will very briefly rush through the first half of the slides, which have been presented earlier. I presume some of you may have seen a recording of that presentation. If not, you can certainly do this after this presentation if you're intrigued about the details. So the second part of the presentation, which is additional content that I think explains exactly what we want to do with this initiative that I'm introducing here. And then I'm keen to open the floor for Q&A because we are interested in getting learning about which countries are interested in participating in this initiative right from the first stage, which we're at now. So this presentation here is titled From Projects to Products, then Product Platforms, and onwards to Platform Co-ops. So where do we come from with S23M? In case you haven't come across us within AeHIN, so we are a small company operating in Aotearoa, New Zealand, and in Australia. Our values are as follows. So we ensure independence by being entirely employee-owned, so we don't have external investors. As Cha mentioned, we've been around now for over 22 years. We appreciate diversity as a fundamental building block for thriving communities, and we offer related professional education in the health sector. We elevate the voices of marginalized people as part of working towards equitable access to healthcare services and better health outcomes. We invest in people, in each other, and in trusted relationships with our clients and partners, and as importantly, in trusted relationships with members from marginalized groups that intersect our team, the teams of our clients, and the communities we engage with. We consider local communities to be the most important source of knowledge and wisdom for health service design and allocation of limited resources. So this goes back a number of years. We've been specializing in the healthcare sector now, I think, for probably, something like 8 years. And this is, I think, a quote that I always like to repeat from Kerry Nuku, who heads the New Zealand Nurses Association. So she's observing, we've got to find a mechanism that we don't complicate access to services and diminish the quality of life just because of bureaucracy. We've got to make sure that we free up services to get to where they're needed. And I think this is very important, in the space that we operate here in terms of interoperability and digital health and digital technologies in healthcare. We always, I think, need to keep this observation in mind. So, as I said, I want to go through these slides here very quickly. So this is about this transition from a project mindset to a product mindset, and then a so-called product platform mindset. So when, for example, you're using a methodology like Scrum, this tends to be used in the context of, you're dealing with a project, basically. So it's a unique situation you're in. So the batch size is one, and there's one project you're working on. Of course, this can be part of product development, but it doesn't have to be. So that's a key observation. So I'm not saying that Scrum is completely irrelevant in the context of developing products. So, and there's a mindset that goes with managing projects and executing projects. Now, at the other end, we've got products. Here as a simple example of a product. So very simple configuration. So the batch size could be in the thousands, and the total volume in the tens of thousands or possibly more. And then what we are really interested here is this concept of a product line. And so there we're dealing with complex products and simple configuration. So if you purchase a car these days, well, you can configure this to your needs and preferences, right? So it's mass customization. So you typically purchase or order one car, but in total, these things are produced also in the tens of thousands or hundreds of thousands. So, and the interesting thing here is to observe the simplicity of the configuration, right? You as a customer can do this. Now, there are also other kinds of product lines where you're dealing with a very complex product and complex configuration. So in this case, the batch size is between 5 and 100 maybe, and the total volume over 500. So here we're talking airliners, right? And these aircraft are, as you know, I mean, there are only two big manufacturers globally, or possibly 3 or 4, depending on how you want to count. But very few manufacturers who are in this particular industry, and they dominate the market. And as you will also know, well, there's systematic reuse there. So in terms of engines, airframes, and so forth. And interestingly, the configuration is so complex, it tends to be done by airlines rather than the airframe manufacturers. So that's where it starts to get interesting. Here's an interesting boundary case. So you may not know what this is. This is a small steam turbine. The ones you find in power stations tend to be much larger. So the length might be something like 50 meters. And these are very expensive things, costing in the hundreds of millions of dollars. So I'm talking about the cost of a power station. And they're complex, and the configuration is also complex. The batch size tends to be really small, and the volume also relatively small. Why I'm calling this a boundary case is because each steam turbine is tailored. The blade configuration, the shapes of the blades are tailored to the environmental conditions of the power station. The temperature of the river that's next to it, and so forth. So this is an interesting case because what we want to do in the digital world, of course, we want to try and simplify. So you'll be familiar with this whenever you're dealing with complex software and you want to implement it. Many established products also in the space of healthcare and digital health, we're dealing with complicated products and complicated configuration. Notice the words I'm using here. I'm not saying complex. I'm using complicated because it's overly complex, right? There's spurious complexity involved in configuring these things. So, and this is why, for example, the implementation of an ERP software or electronic health records management system can feel much more like a project than purchasing a product. It feels very different, certainly, from, say, purchasing a car. So what we want to do is we want to ideally get to a place where we strip out the spurious complexity so that we don't we don't want to compromise on functionality, so we'll still have a complex product. Just think of the airliner. So it's still complex. The configuration is also complex, but we don't want to overcomplicate things. So that's where we want to get to. And I'll skip over the next slides. You can listen to this in the other presentation, or you can just read it later. The problems with the IT mindset, which is basically the project mindset. This then Yeah, there's issues with approaching everything as a project and a project management mindset. So you typically transition from a project mindset to a product mindset when you realize that there's demand for 3 or more customers for some solution, right? So this is how many products in the digital space come about. Start with one solution, and then at some point you realize, well, there's more opportunities. So let's try and commercialize this. But then, of course, if you're dealing with non-trivial software, you then need to configure these things. You discover that, oh, we need to have some parameters here so that it's really generalizable. And in the product mindset, this configurability is an afterthought. And so that's different when you notice that you're running into bottlenecks with product configuration. So due to the complexity of the requirements, and often you only have a limited number of people with critical configuration domain knowledge. So once you demand, now, let's say if you have, suddenly you want to have, well, if there's demand from 100 or 1,000 or more customers, then you start to feel that pain, right? If you haven't taken a product line approach. And you may wonder what product lines are about. Well, we can draw an analogy here to mass customization. Mass customization is about achieving a tremendous increase in variety and customization without the corresponding increase in costs. So think about the car example. It's the method of effectively pre-tailoring the product to the idiosyncrasies of every user. And it postpones the task of differentiating a product until the last possible point in the supply network. So in the case of purchasing a car, well, you as a customer do this. We also have simpler examples with shoes these days, right? So the methodology that we use in the space of digital data-intensive solutions in healthcare is what we call model-oriented domain analysis and engineering. So this is the methodology for product line engineering. So this offers a systematic approach for conducting commonality and variability analysis across the needs of all customers and potential prospects. And for sourcing and surfacing the domain knowledge needed to hide all implementation details from users of configuration tools, so that most of these tools can be operated by customers. So this is our proven and time-tested method of effectively minimizing the complexity of configuration by pre-tailoring the product to the idiosyncrasies of every category of user. And this hands the task of differentiating a product for a specific category of user to power users of that category. So for example, if you're having, say, electronic health record management system, well, you have medical doctors, nurses, dentists, and administrators interacting with that software. So those are the categories of users, and they all have different needs. So a concrete example with Airbus, for example, here you see their product lines and product families, right? And there's systematic reuse. This is the characteristic of product line engineering. And this is a discipline that's been around for 30, probably close to 40 years now. It's got a long track record, and we've been using it for decades. But fact is that it's actually very rare amongst software organizations to take this kind of approach. If you think about SAP, for example, they have this whole ecosystem of implementation partners, right? And this entire ecosystem makes more money by having these highly complex, and I would say overcomplicated ways of configuring the software. This is the sad reality. Once a company like SAP has cornered the market, if they dominate, then they can exert this kind of power. And this is not in the interest of the people wanting to use this kind of software. So this is why only few software companies go down this route. So how does product line engineering work? I want to be fast now so that we get to the second part of the presentation. So basically, you have timeless thinking tools and design principles for structuring the work. And so that includes techniques for asking the right questions to surface all this tacit knowledge that uncovers the dimensions of variability that are relevant in the configuration space. Now, in terms of organizing the work, there are 4 work streams, and you've got dedicated teams in each of these work streams. So that makes it different from what you may be familiar with when you're doing projects or when you are implementing products and using products or even developing products. This is different, right? Because the people who are building products, well, this is known here as product engineering. Well, they're basically working with building blocks that have been derived from domain analysis. So that's where the systematic reuse comes from. So this is like building with powerful Lego blocks, right? And as with the car example, you want to equip domain experts to do this. So we want to, if you do this in, say, in the space of healthcare, you want to equip power users who may be medical doctors, nurses, and so forth to configure and assemble solutions. So that's a radical shift because you don't have software engineers working in this space. And then product line operations is basically, well, the using of the solution. So that's, say, if as a medical doctor, you just, as part of your clinics, making use of a medical record software and so forth. Now, the interesting work here goes on, obviously, in the so-called platform engineering. And this is where these reusable building blocks, they are called reusable assets, are co-created in closest collaboration with the users, the user community. So that's why we see these feedback loops here. And these building blocks, by the way, they're not limited to software components. So those can be methodological building blocks. They can be reusable parts of reusable configuration elements. So if you've had one configuration that worked in one community and a very similar configuration works somewhere else, the commonality, you can distill that into reusable assets. So, and the art of doing this systematically and then making these reusable building blocks available in a highly tool-supported automated system. This is what platform engineering is about. And so here you have technologists working who understand software engineering and many other disciplines. And as part of doing this, you may need to conduct experiments. So that's another work stream where if you need to integrate new implementation technologies, emerging technologies into your product platform or product families, then you want to first conduct rigorous experiments before you take on board these things and build them into usable assets. Because if you don't do this systematically and with great care, you may be impacting hundreds and thousands and tens of thousands of users. You can't afford to do this, right? So this is a very high level of maturity here. And so here, in terms of the frequency of events, product line operations, that's the daily business. So they are dealing with daily events. So that's why the red hot sort of fast change, that's the color we use to represent this. Then we want to certainly speed up the configuration of solutions. So this is then, you can work on this basically with, they encounter sort of weekly feedback loops, monthly feedback loops. Platform engineering, well, that's where you want to think about this, think solutions through before you give them to the people who are using building blocks. So this is on a slower cycle. Experiments, well, they run on demand, much faster. And the design principles, well, they tend to be timeless. So to sum up, where are we now? Well, this is sort of the evolutionary history of communication, human communication technologies. And we are now in this space where we're dealing with AI, where machines are imitating humans poorly through new interfaces introduced every day. So it's a very rapidly evolving world. So what do we do in practice? With which people do we interact? Well, traditionally, when you're developing products, you may think about the user experience. And so that's the naive way of thinking about products and product specifications. So you think you have a user and a product, and then user experience design is what you're worried about here, and the use cases. Now, as you know, with your focus on interoperability, there's more to this, right? So we live in a complex world. Our systems are talking to each other. So you're familiar here with the interoperability challenge. And in product line engineering, what is also important is the culture co-creation. How do the humans interact in the context of these technologies? So in our work, we pay as much attention to, well, the same level of attention to all three factors here. This is really important because you can think of this like a three-legged stool, right? You kick off one of the three legs and the whole thing falls down. And this is perhaps also why product line engineering is not widely used, because often people only think about the user experience design, or, well, if you're lucky, they are also thinking about the interoperability, but the impact here at the human level, that's easily ignored. So in terms of the increasing level of maturity and the depth of domain knowledge, you see the overview, what that means in terms of the mindset, what it means in terms of design focus and management focus. So you're moving away from the idea of solution delivery and project management towards ultimately product line operations and product family management. So you're actively managing this set of reusable assets. Now let's cut over to the human context. As I mentioned, we appreciate diversity a great deal within our company and beyond. So the two traits, interestingly, of the best problem-solving teams tend to be cognitive diversity and psychological safety. So this is what you'll see in many of the remaining part of this presentation. We're going to talk about various aspects of this. So the sole domain of human factors is huge, right? So we have physical limits, so that has implications in terms of ergonomics, health and safety, etc. We have cognitive and emotional limits, so you've got the implications of Dunbar's number, so we can only maintain 150 or so relationships at most. There's the impact of trauma on people. This is a real issue, I think, in healthcare, amongst other things. Then there's this whole big topic of psychological and cultural safety, and this has many dimensions. So there's the diversity of cultures, ethnicities, religions. There is the neurodivergence, so this entire neurodiversity movement, the LGBTQIA rights movement, the disability rights movement based on the social model of disability. And then also often, age is a factor, right? Often we don't seriously consider the needs of the children and those who are older than, say, 65. We are conducting participatory research on these kinds of topics. So here's an interesting set of graphs and statistics. So those are employees working in the healthcare sector. And so you see some data as to how safe they feel amongst their peers, with their bosses, with their customers or patients, and then with suppliers. So that means with the bosses, well, over half of employees in healthcare often or always don't feel they can be their authentic self, right? So that is quite concerning. And it's worse for neurodivergent employees. So look at those numbers here, right? So in a nutshell, the work culture in the health sector is not a culture that is conducive to collaboration, to creativity, to innovation. And so we, within our methodology, are very conscious of this, and therefore we place a great emphasis on creating an environment that is a safer place for everyone. Our experience as a small company, you can see it here. So we operate as a worker co-op, so we are employee owned. Our clients tend to be larger organizations, unions, professional bodies, and healthcare service providers or IT service providers. And then at the other end, in our network, we're connected to a range of interesting organizations and communities. So there's the Design Justice Network, there's neurodivergent people, so autistic people and otherwise neurodivergent people and disabled people. We interact with Maori communities and of course with healthcare professionals. And alongside our worker co-op, I'm also involved in the Autistic Collaboration Trust. So this is an organization that, well, I'll show this on the next slide here, that provides peer support and that co-creates communities, community spaces for neurodivergent people that are safe, provides public education, and does this kind of intersectional research. So over here, so this is, well, and you can ask, well, how do these things all fit together? Well, you see this here that the worker co-op gets paid for the work that we do. And then we sponsor the Autistic Collaboration Trust, and this is a charitable organization. So if you look at the bigger picture, then we're basically the main funder of the Autistic Collaboration Trust. All right, so now we're getting to AeHIN, to the COIL network, and what we want to do here. So our tagline is enabling knowledge to flow to all the places where it can be put to good use. And we think there is an opportunity here to activate all the tacit knowledge in the COIL network. And this available regional domain expertise and collective tacit knowledge within this network, I think, allows us to address wicked problems that no country is in a position to tackle in isolation, that no market or EMR vendor has an incentive to tackle, that no vendor consortium developed technology standard is equipped to handle, and that no university is resourced to tackle in a timely manner. So in concrete terms, this is what we are proposing and what we have been discussing with a number of people already here within the AeHIN community, and you are invited to join our conversations and to think about whether you want to be part of this or whether your country can perhaps be part of this at this stage. And now the remaining slides now are about the steps and then what does this entail and what's the context. What exactly are we trying to do? So I'll start with this overview here. So what we're proposing is to set up a so-called worker platform co-op. For now, we're calling this the Open Care Asia Platform Co-op. And with the goal of creating reusable assets, applying a product line approach to this, and then offering electronic health record management software as a service to participating countries, and doing this professionally with professional support. That's the key thing here. So this is an organization that not only develops these assets, but also operates these SaaS solutions. And from an S23M perspective, well, we can support all of this with our methodology and our expertise. So we've been doing this kind of stuff for, well, as I was saying, I think over 20 years now. So we bring deep expertise to this, and we see this real opportunity to create software as a service solutions that are professionally supported, that are based on open source software like OpenMRS. So we leverage all these assets that exist. We leverage the tacit knowledge about specific geographies, how healthcare operates in various countries, and build that into a worker co-op that that isn't capitalized in the traditional sense. So there's no profit motive. There is no investors that expect a ridiculous return on investment. So this is up to countries to co-fund. And then the worker co-op here is a self-managing entity. And we've written a longer let's call it proposal or discussion paper that outlines how this can be scaled out and adopted at larger scales once it's operational and once people can see that it works and that it works well. Then, of course, we want, or the intention is to enable AeHIN member countries to jump on board and to participate in this. So the organizational pattern for operating a product line organization looks something like this. So in this slide, I've already sort of adopted the terminology from the previous slides. So let's just briefly go back. So here you've got this platform co-op that we're talking about, which is closely related to, I'll talk about this later, the open care metadata community. And I'll explain exactly what this is. So this is basically where the tacit knowledge about how healthcare operates in particular countries comes from. This is really important. And it's this community here that acts like the steering group for this platform co-op. That's why you see this here, open care metadata community goes across all functions of this platform co-op. So within the platform co-op, you see these work streams that we saw earlier, the operational side, the application engineering, where solutions are configured from reusable building blocks. And these reusable building blocks, they are part of this platform engineering here. And of course, all these work streams here where you're doing engineering type work, well, you've got project management, you've got an architecture, you've got quality assurance, and doing this with professional, fully staffed teams. This is the key thing. This is not possible to do this as a side job. It doesn't work. And in order for this software as a service model to really work, what's really important is to have a fully professionalized help desk, which is not only first level support, but it needs to have this integrated second level support where the application engineering and the platform engineering teams get involved to assist when that's needed. And also third level support where, let's say we do this and we use compute power from Amazon and storage from Amazon or Google, then, that's where the third level of support needs to be integrated. Just briefly, this is the context where we come from with S23M and the Aotearoa New Zealand Interoperability Lab. We also are, as you can see here, connected closely to a number of academic research institutes and public health research teams. So that's where it also gets interesting in terms of doing more than just electronics health records management as a service. The idea is that over time, we can build in solutions that come from research and we can also operationalize them, right? We then have the professional know-how in the right places in order to be able to do that systematically. So we not only want to make the world a safer place, but also a healthier place for everyone, right? So that's the purpose. I mean, this co-op really is intended to support healthcare delivery and improve health outcomes in participating countries. Now, what expertise do we bring to the table in terms of operating a worker co-op? Well, so I've summarized this on the following slides. So this is where you now learn how we operate our small worker co-op, and we've been operating this way for over 12 years now. And we have a longer history, so 22 years. So we've operated as a traditional company in the past, but we adopted the worker co-op model for a number of reasons. Here you have 8 principles that we apply, and the purpose of these principles, I'll just sum this up here. So we're interested in being resilient, and we achieve this by revenue sharing instead of paying ourselves salary, and we do this in a very egalitarian way. We have a culture of thinking and learning, and these are these thinking tools that are also relevant in the product line engineering context. The employee ownership ensures that there are no distractions by stakeholders with short-term motivations and possibly hidden agendas. We have an intensive induction and onboarding process, so that's a foundation for developing mutual understanding. So we know how to basically take on board new people, get them up to speed and running. And we organize everything around the talents that people bring. So instead of having preconceived notion as to who should, what a particular role should be doing. So this allows us to benefit from an incredible diversity of talents. And as I said, we're very egalitarian, and that means we only have team-oriented incentives and 0 individual incentives. And this eliminates in-group competition, which tends to plague corporate structures. We operate an advice process instead of hierarchy, so we know how to learn from each other. We actually do this, I think, much better than traditional organizations, so we maximize learning opportunities. And in terms of IP, we open source, basically our operating model, we are supportive of open source software and open source knowledge. So we don't want to create any barriers to flows of tacit knowledge. And that results in mutual trust. And there's also a scientific background to all of this. I encourage everyone to look into the pioneering work of Elinor Ostrom on the management of shared resources. So she was an economist by trade, and she got the Nobel Prize in economics for her work on this topic. And so she came up with these 8 core design principles for collaboration and management of shared resources, and we've adopted those, and they work extremely well. So we've modified one here. This usually reads strong group identity, but here's the thing: we work with very diverse people. Our team is very diverse, and so we focus on trusted relationships, and the quality of these relationships is everything. And that, of course, then ultimately leads to a strong group identity. And importantly, we support neurodivergent team members with collaboration patterns that respect the needs generated by unique sensory profiles and physical and hidden disabilities. I think many of these things are fairly self-explanatory. In the design principles from Elinor Ostrom, there's this idea of tracking agreed upon behaviors. What we know, however, from highly egalitarian organizations is that if you have a working advice process where people simply are obliged to seek advice from peers before arriving at important decisions that affect others, then actually this is a proactive approach where the formal tracking, the need for that is then minimized. And similarly here, the graduated responses to transgressions, the more sort of egalitarian you operate, the more this can focus squarely on one objective, and that is to prevent a person or a subgroup from gaining power over others. So that makes it very simple. Now, I want to cut over to this broader topic of public health and One Health, I think, which has become really to the forefront with the pandemic. So, and there I would like to remind everyone of human cognitive and emotional limits, and recognizing that these limits that we all have as humans are as real, immutable, and relevant for our survival as the laws of physics. And this allows us to embark on a path of collective learning. And One Health is transdisciplinary. So here you see the space dimension from very small to very large, time dimension from very short to very long. And so yeah, I've mapped out sort of the disciplines that come into play, right? Everything from physics, I mean, medicine is part of the picture, but there are many others, right? Depending on what sort of spatial and temporal scales you're looking at. And then design and engineering fits in somewhere here, right? So, and so just bear this in mind. I mean, we understand only very little about the world that we live in. So we live on this huge planet, and yet we are humans. Our human scale is, well, we live in households, we have a family, and then beyond the family, we are limited by Dunbar's number. So there's only so much that we can understand. So this is what I'm trying to illustrate here. So ultimately, I think humans, well, the living planet is teaching us every day that humans are not in control. We are part of the earth, and this little dot here is intended to symbolize how much we actually can possibly comprehend as individuals. And this, I think, perhaps reinforces this notion that, well, we better get good at collaborating and sharing knowledge and assisting each other with the different things that we know. On this note, there's the Design Justice Network and the Design Justice Principles. So I'll just skip over this. Well, don't want to get lost in the details here, but the key thing here is about design. We see the role as the designer as a facilitator rather than an expert. So it's not about, the designer coming along being the person who knows everything. No, it's facilitating a transdisciplinary process with many different perspectives and stakeholders. What we found very important as the ultimate foundation is to rediscover the language of life. So in our language, we talk about care rather than communication, talk about catalysts rather than leaders, right? So to get things done and distribute decision-making to where the knowledge actually resides. We talk about competency networks rather than leaderships. We talk about coordination rather than management, to address the cognitive load that can increasingly be automated to avoid the perpetuation of social power gradients. So we talk about courage rather than fear, creative collaboration rather than best practices, because things evolve, right? So you may need to adapt your so-called best practices when the environment is rapidly changing. We value the currency of knowledge and the transparency of information rather than the liquidity of money and so forth. We talk about ecologies rather than economies, to co-create ecologies of care instead of economies of commodified goods and services, to create environments that are conducive to life. There's more of this, so I think we don't have time to go through all of this. I encourage you to read the slides in detail. I think you'll find this very useful and helpful, and this will give you context for why we firmly stand behind this idea of operating this as a worker co-op, and we see this as creating a very different set of incentives for all stakeholders than if this were a commercial entity. So in terms of methodology, here you see elements of the methodology that we're using. So we talk about the ecological lens, which is a modeling language for evolving ecosystems. Well, actually, more accurately speaking, this is a meta-modeling language. So because we can use this meta-modeling language to basically record and capture and formalize cultural patterns that exist in different settings. For example, in the healthcare delivery landscape in a particular country. At a more detailed level, you see this here, and we have education courses on this. So this just gives you an idea how this might look like. So there's, as you can see here, the element of co-design, and then once you have a design, you act on it, do all these different things. Then you share, you make this knowledge, what you learn, externally available. So you can then describe this in terms of resources, events, and agents. Then you can combine this in creative ways. Then you can decide what to focus on, and then you internalize this, and again, it feeds into the cycle. So we've got education courses on this whole topic. Now, where are we at now? What are the next steps? We've written a longer discussion paper that has been shared with AeHIN, so you can get access to this. And then there are these presentations, and we invite your input and feedback. Exactly where we're at now is we're at this place of getting started. So to start, we are currently seeking committed support, ideally from 3 countries. 2 might possibly work, 4 would also be okay, but we don't want more than 4 because we want to and we're interested in a diversity of countries participating so that we can conduct an interesting commonality and variability analysis. So the first 2 steps here that can then be conducted in parallel once we've got the support from let's say 3 countries is, first of all, we can conduct an initial commonality and variability analysis, time boxed to a maximum of 6 months, using this methodology that I've outlined, and representing the results in an instance of this OpenKR metadata model. As part of this, we'll be learning a lot. And in parallel, the people involved in doing this will also be involved in co-creating a fully developed proposal for a platform co-op. So the idea is not to set up a platform co-op now and then we first want to do some homework here and to develop an in-depth proposal with the countries that are interested in participating, so that then the governments involved, the ministries of health involved, can decide whether they actually want to jump on board. So there's another milestone after these 6 months. That's very important. This, now in more concrete terms, this commonality and variability analysis, this initial phase, we'll be looking at the specific ways in which all these different categories of users interact with medical record systems and other digital systems. So we've got doctors, nurses, midwives, dentists, sanitation engineers, IT administrators, patients and their families, and possibly further categories, right? So all of these categories here, these different roles, they have a particular perspective and particular use cases. We need to understand them and also understand the conceptual, the terminologies, the thinking models that these different people use in their work. Then, based on this, we also need to pay attention to the commonalities and differences that depend on local context parameters. So that is where it gets interesting to look at different countries, how this plays out. So there might be urban sites that are on the lookout for interoperable systems. There might be rural sites that are in the same boat but have less resources. There may be rural sites with strong advocates or catalysts, and then there may be other factors that may only emerge as we're doing this initial phase of the analysis. And then domain analysis goes further and asks about the rates at which the work of each of the above roles and each of the local context parameters tend to vary and change over time, and over which time frames. For example, there may be some changes that follow seasonal patterns, other changes that reflect demographic changes that are in progress, say urbanization, something like that, or changes made possible by investments in internet and digital communication infrastructure, etc. So that means the way you're using software and how the optimal configuration tends to evolve over time, right? So domain analysis will uncover all of this so that we get a good handle on this. And as I said, we need to do this ideally across 3 or 4 countries. And this then gives us a solid foundation for distilling reusable assets and creating a configuration space that will turn out then to be actually well equipped, not only to serve those initial, say, 3 countries, but also further countries. And of course, as further countries then come on board, of course, the configuration space may also be further sort of elaborated or refined. But the intent is to get started, with a really good foundation that isn't plagued by spurious complexity that's unneeded. So we are not going to speculate on what things may vary, but we're going to work with concrete requirements. So this may all sound extremely abstract. I realize this if you haven't done anything similar to this point. On our website, there's a 5-minute explanatory video that walks you through the key elements of commonality and variability analysis in a relatively simple example from a different domain. So please go to our website and you can learn more about this. You may find this quite interesting. Then in terms of developing this proposal for a platform co-op, well, this again needs to be done incrementally in a well-coordinated way. And this is where we can, however, build on the well-established design pattern here for a product line organization, right? So we don't need to reinvent this. We know how this works. I've talked about this, I think, in the other slide. And having dedicated teams as highlighted here, I think that's going to be important. Think of these, when we set this up, when we hire the initial people, these are going to be dedicated teams structured in this way. And the customers in this case would be healthcare delivery organizations. They can also be co-ops, ideally, in the participating countries. When we get started, to manage the complexity of, the operational healthcare delivery models in participating countries, we'll need to distinguish between enterprise architecture and domain architecture. So remember that this platform co-op, where we are with the software as a service model, we intend to service the entire healthcare delivery ecosystem. Ultimately, initially will be a first few healthcare service delivery organizations, but we have the broader ecosystem in mind, and the structure of how this ecosystem works, how primary healthcare interacts with secondary and tertiary care, how this interacts with the local way in which insurance works, how things play out in different, urban versus rural and so forth. These structural differences, that's what we refer to here as this domain architecture, right? So this is stuff that sits outside your, let's say, your EMR software. So this is this structural system level knowledge that we are going to distill. And this is going to enable or radically simplify the configuration of various pieces of software. And in this context, the open care metadata community that I mentioned will be involved in surfacing all this knowledge. So this is all the stakeholders who actively contribute relevant local perspectives, priorities, and domain knowledge. And so it is this important community that acts as the steering group or the governance board for this proposed Open Care Asia platform co-op. And this effectively breaks through the barriers of disciplines and organizational silos to power a continuous omnidirectional socialization, externalization, combination, and internalization knowledge creation spiral. So you see this here. So this is about taking tacit knowledge, making it explicit, combining it, then again internalizing it so it becomes tacit again, and then you socialize it, and then you make it explicit again. So this is a well understood way of knowledge co-creation. We make use of this in so-called domain analysis workshops. We also make use of it in open space workshops, which are excellent for engaging with all kinds of communities. In terms of the, so here we just have an outline as to how this then continues after the first stage. So this would then be committing to implementation, and then it's about hiring a first team, then designing a dedicated Asia-Pacific specific OpenMRS configuration module based on the care platform metadata model. And then expanding the team to include minimal support for DevOps, user support, and training, and then making OpenMRS available to participating countries in the form of a software as a service model for with this specific configuration module, so that the intention is to make this very easy to use so that power users can configure this for their peers. So that's the difference, I think, to traditional ways of going about this. And then incrementally roll this out to selected health service providers. And then we can also, at that point, once this is operational, invite One Health and public health researchers to integrate further practices and results from their research, which might be, additionally useful public health related tools into this software as a service delivery model. And of course, we then want to engage in continuous improvement, learn incrementally as we go, and organically grow the team, and as needed, then scale this out to further countries. This is the last slide here. Conscious we've used up quite a bit of time. So to sum up, we are now gathering committed support from 3 or 4 ministries of health. We're aware that there's great interest in the Philippines in all of this. And so we're looking for 2 or 3 further countries who are interested here. And the idea with this presentation and the earlier presentation that you can, I think, find on the AeHIN website is to give you enough context to decide whether your country is in a good position to participate at this stage. And this then allows us to assess which interested countries are generally committed to investing at the time and effort and funding needed to get this first stage of this initiative off the ground in November this year. So we want to get this off the ground fairly soon, because the first stage, what it really is, it's a specification stage. It's a knowledge elicitation stage where a lot of valuable tacit knowledge gets surfaced, documented, and then put into this proposal that should ultimately, I think, be very compelling to the countries that have signed up. Yeah, I'll finish here, and I'll see Alvin there. Thank you very much, Alvin, again, for enabling all of this. Thank you.
Thank you, Jorn. So yeah, just to repeat, the Philippines, we're organizing ourselves to be one of the countries to participate in this cooperative. But if there are questions from the audience, please just open your microphone or type your question. If you're not, if you think there are people or groups within your country that will be interested in this, let us know. The reason we're interested is we've been using OpenMRS since 2010 for a customized electronic medical record for our government frontline clinic. So it's old. So we want to go to the next version. But we realized in the 2010 version that we use OpenMRS version 2, we had different concept dictionaries in our implementations, and that caused a lot of headache. So if we knew about the product line approach, maybe we could have avoided some of the problems. Anyway, I think it's time to refresh to the newest version of OpenMRS. And then now we will do the product line approach. But more than that, our objective is to empower the communities to take care of their own OpenMRS implementations, uh, because they're closer to their frontline workers. They're better able to support them. But at the same time, we don't want to fork, so to speak, the core functionality. We want to have a common functionality all over the country, because we will be connecting it to the insurance system. There will be money coming in for if they use the EMR very well. So we want to make all of those solid, but we also want them to innovate and be able to solve their own health problems, and we want to empower them to do that. And I think it's a combination of software and training. So from Dr. Aminul, how do you store tacit knowledge within the organization?
Uh,
Go ahead.
hi, Alvin. I would like to thank Jorn for a good presentations. There are a lot of things that I learned from your session, but my question is that in healthcare industry, there are a lot of times we see that institutional memory often lost, and we do same things again and again. So my question is, how do you store the tacit knowledge within the organization as an institutional memory so that it never lost and it can be reused? So it is engineered in your platform that you mentioned in the presentation. So somehow the architectural point of view, I'm just asking you. And how do you think about the explicit to tacit and tacit to explicit in both, vice versa, so that the employees of the institution can reuse and utilize the knowledge, for the decision making? Thank you.
Yeah. I love these questions there, right? Well, they get to the heart of it all, because the we consider the tacit knowledge to be as important as the explicit knowledge. And we are very conscious of this. So the tacit knowledge needs to be kept alive at all times in parallel to the explicit knowledge, right? So I think this is a common, misconception amongst sort of administrators who are unfamiliar with how, well, things work when it comes to in-depth domain knowledge in the context of digital systems, that they think once you've got a solution that works, then you no longer need the tacit knowledge, right? That's just like optional. And the reality is you need to really nurture the tacit knowledge. And we do this systematically. Well, you saw these different work streams and these feedback loops. So these feedback loops, we practice them. And then there's this advice process. Amongst other things, for any particular area of knowledge, we ensure that there's at least two people that are involved and up to date at the same time, right? So it's basically you cannot allow to have anything there that only one person understands. That's not a good idea. Um, and and this also actually gets to this point of where I'm arguing, we want to do this in this worker co-op that is very much self-governed. Of course, the requirements need to come from the ministries of health and the ecosystem within the country. But in terms of how the work is organized, if it's this worker co-op where we cultivate, well, a healthy work culture and where people have, are employed, it becomes their full-time job, then, and in particular, yeah, one of the other things that you'll find in our proposal document is to also, well, to focus on employing people from marginalized groups, because having those kinds of people within the core team, what this does is they're basically not only working on this kind of solution, but they're also representing and are cognizant of some of the needs of these marginalized groups, right? So there's like a more intimate connection to the people who are, well, the patients and their communities. So that, and our experience with the worker co-op model is this creates very long-lasting relationships. So you don't have the kind of churn that you have, say, in a corporate environment where people, they work for one vendor for a few years and then they look around where they can get a better offer and then they're gone, right? I think this is different here, especially if we focus on MRS and other open source software where we have an explicit emphasis on developing all these relationships with all these various communities. And the organization itself then, well, now I think I've talked a lot about how we manage the tacit knowledge. The explicit knowledge, well, this is why we talk about model-oriented domain analysis and engineering. We store the explicit knowledge in formal models, and we have the meta language to do this already. So that means we know how to go about, formalizing this kind of knowledge in a way that not only assists human, additional employees or stakeholders to get familiar with it in a visual form, but in this formal format, this knowledge is also accessible to software tools. So it can be used to advanced forms of automation, right? So for example, we have a formal model of how your, say, primary healthcare is organized in a particular set of communities. If we've got that sitting in models, then we can use this to automate the configuration of, say, EMR type software like OpenMRS, right? We can use techniques like code generation and template languages to automate the link between these structural models of healthcare with the EMR software. And we've done this in the commercial space in other industries many times. So for example, in Switzerland, I've worked with vendors of software for banks, right? And so like SAP, they have this challenge of, well, if a new bank wants to use this software, it's terribly complicated to configure. So we've simplified this kind of configuration by orders of magnitude. We've done this with Siemens Postal Automation and in other places. And we see we can do exactly the same here in the domain of healthcare. And if we combine this, I think, with open source, where also there's this community spirit of open knowledge sharing, this fits together really, really well. So, and that's why we talk about this, well, metadata management community, which again is a community that is transnational, all the participating countries. The idea is to share that knowledge, to make it accessible, and of course, then to make sure that every country has at least two people involved. Well, many more actually, with all these different roles. So, but I hope this gives you an initial idea as to how that works. I mean, we've got so much more information on this, but yeah, I realize we're running out of time here.
We have one question from Ahmad from Indonesia. Ahmad, do you want to ask this question? Do you have a process for analyzing health data to inspire innovation, followed by, oh, there, Ahmad, please go ahead.
Yeah, thank you, Alvin. And Jorn, thank you very much for the presentation. Yeah, I'm just wondering if you have the process prior to developing the solution itself to analyze the health data and then go through some ideas through the design thinking process to create some possible solutions, then test that possible solution into the sandboxing prior to develop the real solution itself.
Yeah. This question that you have there, it touches on, I think, several topics. So you may remember, first of all, there are these different work streams, right? Experimentation versus platform engineering versus product engineering. And so this is how the different parts of the solution finding process is organized in terms of teams. But then, of course, you always, well, where does the tacit knowledge comes from? It often comes from, well, before I go on too much, you mentioned analyzing health data. Exactly what do you mean? Do you mean patient records, or do you mean?
Yes.
All right. Yeah.
Yeah. Let's say in the community that we have so many different kind of issues as you address the One Health, right?
Yeah.
And then we might select some of them, not all, of course. And that's the way I'm thinking that how to select the priority of the solution that we want to develop.
What I would highly recommend there is to engage communities on the ground. So there is, of course, the clinician perspective, right, or the healthcare service delivery provider perspective, but then there are the actual communities with the patients and so forth. And I would recommend to combine these perspectives. So we've got experience in conducting participatory research with various communities. So what I would recommend to do is to, yes, on the one hand, let's say you've got your patient records where you have statistics, about well, what you experience in your clinical environment, but you probably also want to have the direct perspectives from communities and patients and their expectations and their experience with how things currently work, right? And you want to actively involve them in the creative process. So, and it's in that context that so-called open space workshops can also be very effective. So participatory research is one way, for example, to get anonymous feedback also, so where people don't need to be, afraid that if they critique something that this will reflect badly on them ultimately. So that's an anonymous channel, but then open space workshops can be constructed so that people can, well, also engage more interactively, and it doesn't have to be anonymous. And I think, yeah, we've made very positive experiences in open space workshops where you have patients and clinicians, right? I think this is a very, very healthy kind of innovative environment. And I can tell you that the main thing is, and this is why open space, if you're not familiar with it, read up on this. Open space comes out of the healthcare sector and it works extremely well because it is self-organizing, and if you create a safe environment there, the most important thing is people want to be taken seriously, right? If you have patients, take them seriously. If that's, I think, and if they then see this reflected in the design process, then you've got them on board. Similarly with clinicians, if we involve clinicians in and listen to their preferences when it comes to, well, how does the software need to operate so that they can get through their workload, right? Then, and if they see this actioned, then they'll like this. And so we are also not imposing any terminology on anyone, right? So just listening to people, soaking up their terminologies and so forth. We want to build all this into the configuration space. So in order to make life easy for all participating stakeholders. So this is about allowing every stakeholder to interact with the system in their familiar terminology and thinking patterns, which are, of course, also shaped by the way healthcare operates in a particular country, right? So you are located in Indonesia, right? And your colleagues will understand how healthcare is organized there, and you have terminology to talk about this. You need to be able to see this reflected directly in your system. You don't want to need to translate this into some language that seems foreign because it like comes from a vendor or something like that, that's outside the country.
Yeah. Thank you, Jorn.
Your last 3 minutes, next steps. Count me in, Philippines. Maybe we can get others. I already texted an invitation to the participants, but I think we just need to continue advocating for this. I was thinking, like for the Philippines, we can already do the product line with at least 3 different facilities. But of course, if we get 1 or 2 more countries, then that would really attract funding opportunities. So if anyone in the audience right now has any knowledge of any OpenMRS implementation, that's a quick win because we can just like invite them to join this cooperative. I know there was one in Indonesia, but I lost track of them. And there's a lot in Nepal, and I think there's also one in Bhutan. It's just that they're not here. Jorn, go ahead.
Yeah, I mean, I like that also. I see in the chat OpenMRS is mentioned, and I know that from our earlier discussions that some countries have had challenges adopting OpenMRS and keeping up with changes, and this is precisely because well, it's open source software and it works well, but you need technical expertise to get it up and running and to maintain it and to upgrade it and so forth. And that's why in this holistic approach with the product line approach and the worker co-op, running it in this way as a software as a service, that's an entirely different kind of model where new countries can come on board, and once it's operational, they can use the servers to configure this to their needs via configuration tools that are tailored to domain experts that are not, so you shouldn't need to be a software engineer to configure this thing for your country or for your community, right? That's the big difference. And as this And of course, over time, the more countries and healthcare service delivery organizations within countries come on board, the more there will be demand, say, for support in terms of help desk and new feature requests and so forth. And then this organization can scale in interesting ways. So initially, we'll start off with one worker co-op across 3 or 4 countries, but then it's obvious as then the demand within these countries picks up, it makes logical sense to actually split this thing up so that there's a dedicated co-op for each jurisdiction. But then each of these co-ops in their DNA, they'll have this tacit knowledge and the access to the explicit knowledge, and we can still, via this metadata management community, right, we still have a systematic process for maintaining these shared assets. So we've thought this through, how this can work. And these shared assets, they're not informal spreadsheets or Word documents, things like this. No, these are formal models that feed into automation tools. So we are very confident about being able to scale this.
Thank you, Jorn. I think it's getting late for everyone. Let me work on the Philippine side. I think Ahmad and we can find the Indonesian side and get the Nepalese also on card. So picture, please, everyone. If you are willing to have your picture taken, please open your webcam, and then Christine or Charisse will take our picture. Jorn, we should continue doing this. November 2024 is a good target. We should keep it there. So that at least we have some timelines. But yeah, let me work on this. I just got busy with APAMI 2024. So
Thanks
apologies.
very much for your support.
All right, thank you.
Thank you. I'll create a group chat so that we'll have faster.
Thank you very much. Thank you, Jan.
Bye.
Thank you, Alvin.
Thanks, everyone.
Dr.
Bye-bye.
Ahmad. Bye, Aminu.
Bye-bye.
Dr. Ahmad, Dr. Ted.
Bye.